Hi, my name is Veronika Kim. I'm the founder of Balansize, comprehensive women well-being mobile app designed to help women save time, reduce stress, find the inner balance at every stage of life. And today we are discussing a topic that affects millions of women worldwide, yet many still suffer in silence. Pelvic pain and infertility, with Professor Dr. Luciano Nardo, consultant in gynecology and expert in reproductive medicine and infertility, and Dr. Charles Nagy, consultant and OBG and high respected specialist in advanced endometriosis surgery and women pelvic health. Hello, doctors.
Hello.
So, understanding pelvic pain, what is normal and what is not, it's a very common question asked for women. And let us start with a question many women ask themselves every month. Is the pelvic pain can mean different things to different women? What are some of the most common causes to see in your practice, doctor?
Thank you. Well, pain as a subject is very subjective from one woman to the other. So severe pain can be normal for one woman, not complaining, and mild pain can be severe in another woman. Pelvic pain in general is a very complex subject. We say that nearly 85% of patients coming to our clinic with severe pelvic pain, they have endometriosis. The rest of the causes could be infection, pelvic inflammatory disease, fibroids, tumors in general in the pelvis, a condition also related to endometriosis called adenomyosis. All these conditions can cause pelvic pain. Also bladder problems, cystitis, bowel problems, anything related to the lower part of the bowel can cause pelvic pain. Also, we have the pelvic nerves. So we have somatic pain in the pelvis radiating to the legs, whether it is from endometriosis or any other tumor. And we have visceral pain. That's pelvic pain related to the organs in the pelvis. Something related to the bowel, we call it dyschezia. Something related to the bladder as well, and from the uterus. So it's complex and it needs comprehensive assessment to reach the right diagnosis in order to guide the patient.
So, what symptoms should every woman pay attention to?
Right. As we said, pain is very subjective. But any woman having pain that disrupts her quality of life is certainly significant to seek attention. I.e., if she can't go to school, she can't go to college, she can't resume her work as normal, she has to stay at home, that is abnormal. Whether it is period pains, pain all the time in between the periods, vague pain in the pelvis, pain during intercourse, pain during defecation or urination, all this that needs attention. That's normal, not normal pain.
Mm-hmm. And is pelvic pain during menstruation always normal, or can something to be sign? Because most of the women said when they have their period, sometimes to be down is okay. What about you, doctor?
Tolerable pelvic pain is acceptable during normal periods. But as I said, pain that affects the quality of life and stops the woman from going about her normal life, that's abnormal and unacceptable. But as we said, pain is subjective. So you could have a significant pathology not causing too much pain. So whenever there is significant period pains, we call it on a scale of 0 to 10, anything above 6 to 7, that is significant pain. That's disrupting her life. Also the same for pelvic pain without a period. Women sometimes complain of pain without a period. And this is also significant and we should not expect it. Mm-hmm. So pain outside the period, pain during sexual relation, pain in going to toilet, or significant period pains are unacceptable. And it should need further assessment definitely.
Great. So many women are hesitate to seek help because they are unsure what to expect. Can you walk us through what a typical first consultation looks like?
Right. The most important thing doctor needs to do for the patient is to listen, number one. To listen to the words of the patient, how to describe the pain and the severity. And we have a structured proforma to assess all the patient's symptoms, even the ones that she doesn't talk about. So we have trigger questions to ask the patient to elaborate more on the type of pain and the severity of pain. And many women even don't talk about certain pains because of cultural background. Some women consider it as a taboo to speak about pain, especially during sexual relation or during the period. So this is very important. We'll put her at ease. We discuss fully her symptoms, and then we move on to investigations depending on the case. The very simple one that we use is the ultrasound scan, a detailed ultrasound scan to assess the common causes for pelvic pain. And then we move on. We can have further investigations depending on the case.
I love that you started in the beginning that you need to listen patient, you need to listen carefully, and you need to understand it because, as you say, right, so many women hesitate to talk about some important things in their life because the society, the cultural effects, and everything. But this is very, very important point. So, Dr. Luciano, I would like to also ask you, how do you approach making women feel safe and understood during that process?
I think apart from listening to patients is also understanding what is the impact that symptoms have on the daily life, quality of life, relationship, and generally in the family and workspace. And once we understand that they have symptoms that can compromise or affect their life, then investigate the symptoms, of course, with their consent, but making sure always that we explain to patients from the very beginning that there is a step-by-step approach. We need to manage their expectations. We need to ensure that they are fully informed about the symptoms and what investigations we may need to carry out in order to investigate the symptoms.
Great. So, as also in in our platform, we always in Balansize, we always speak that about the connection between physical symptoms and emotional well-being and stress, anxiety, and daily balance. So, Dr. Charles, can you tell me from the lifestyle perspective, what small but meaningful habits support women's in the pelvic health?
Right. We always advise a healthy lifestyle, and that is not only healthy diet, but having a routine of regular exercise in addition to the diet, making a hobby even, can actually occupy the woman and draw her attention to any abnormal pelvic pain that arises over a period of time. So this is definitely very important, and something very interesting that we discovered recently, the role of gut microbiome in endometriosis. So most women, they don't know the role of their food into their pelvic pain. And this is something we raise awareness about. The type of food that you're eating can have an impact on your pelvic pain. Also, exercise has a very positive impact. Keeping your weight in a healthy range has a direct impact on the pelvic pain, regardless of the cause, because that increases the level of estrogen that feeds into many causes for pelvic pain, whether it is fibroids or endometriosis.
Great. And Dr. Luciana, does pelvic pain automatically mean fertility challenges?
No, it doesn't. There are two actually groups of patients. And in my experience as a gynecologist and as a consultant in reproductive medicine and infertility, I see patients that come with a fertility problem, and during the process of investigations, we find out actually they have some other symptoms that may be a cause of pelvic pain. And then we have patients that actually come with a history of pelvic pain, and during the process of investigations, we find out that they have some fertility issues. So, for example, there may be women attending a general gynecology clinic presenting with pelvic pain, and after having had an ultrasound scan, there may be some clinical suspicion of pelvic adhesions. They end up having a laparoscopy, and they may have a frozen pelvis with scar tissue that will affect the mobility of the tubes and the ovaries, and inevitably will affect fertility. That is a cause of pelvic pain and infertility. There is another group of patients that may present and they have a diagnostic laparoscopy to assess tubal patency, and during the process of laparoscopy we find out they have severe endometriosis, because there's not always a relationship between symptoms and stage of endometriosis, or they may have also scar tissue that they had no symptoms for. So again, from the very beginning, investigating the patient, listening to the symptoms, and discussing the various steps of a physiopathological process is very important.
Yeah, and what would you like women to know about early understanding of reproductive health, especially in their 20s or 30s?
I think women cannot just be ruling out they have an underlying fertility problem. At any age, women can have a fertility problem. And in this day and age, and in the modern society, perhaps we see that there are women that are better educated, so they seek first and foremost adequate medical advice. But there are also women that are at increased risk of certain conditional diseases that predispose to infertility and may be a cause of pelvic pain. Actually, they are not seeking advice. So we as professionals and we as a community, we should raise awareness about possible causes of pelvic pain, and how in some women, causes of pelvic pain may be an alarm bell for fertility problems.
Great. And Dr. Charles, what about you? What would you recommend?
In my vision as a consultant gynecologist, I advise every woman to keep fertility in mind and don't take it for granted. Even if you're young, I mean, we used to say you should seek fertility before the age of 30. I am talking to women from the age of 20, and I have patients where their period is stopped at the age of 21. So always keep in mind, keep a menstrual calendar, see the regularity of your period, do regular check with the gynecologist to check on the uterus and the ovaries, even before marriage. Now the awareness increased actually, not after the marriage we start talking about fertility. It's definitely before marriage or before a relationship. So we advise many women go for egg freezing, for instance. It's an investment, lifelong investment for your fertility. And it is worth it, whether you have a problem or not. Because in order to find the problem that affects fertility, you need the proper investigations. And how do women know that without having a problem? So regular check from the very early on is strongly advised.
Thank you so much. And endometriosis has become a much more widely discussed topic in recent years. So for women who have heard the term but are unsure exactly what it means, can you explain in the simple terms?
In simple terms, endometriosis is a condition where tissue and cells similar to the lining of the womb grows outside the womb. Once these cells grow outside its normal place, which is the lining of the womb, is considered endometriosis. So if it is within the muscle of the uterus, we call it endometriosis of the muscle of the uterus, adenomyosis. Once it's outside the uterus, it will behave in a similar way like the lining of the womb, starting having bleeding, inflammation, growing blood vessels and nerves into these nodules, causing both anatomical and physiological disruption inside the pelvis. So anatomical will block fallopian tubes. It will affect the ovarian eggs quality. It can cause pain because it's cells in the wrong place. Naturally, our body is trained to deal with these cells and destroy it. But women with endometriosis, due to immune disorder and other genetic problem and epigenetic problems, they're not able, and these cells will continue to grow. Whether it comes from the uterus itself through the retrograde menstruation theory that's most commonly explaining endometriosis, or it grows due to transformation of some of the, what we call it, stem cells hidden in the pelvis. Endometriosis is abnormal cells in the wrong place, and it is a systemic disease. Women think it's only in the pelvis. No, we have seen endometriosis in the lungs, in the pleura, even in the heart, some reports in the brain, very commonly in the bowel, in the bladder.
Wow, but it mainly
Yes,
it comes
but
to in the uterus, correct? That's why it's
it
more
is
associated with the woman health.
exactly.
Okay.
So, but it is a systemic disease that needs a multidisciplinary approach in managing the patient.
And what symptoms may be associated with it?
To summarize it, it's pain, infertility, and dysfunction. Pain with all sorts, because it's a systemic disease. So it could be period pains, pain during intercourse, pain during defecation, emptying your bowel, pain during urination, even nerve-related pain, sciatica pain, or pain radiating down the legs. Also visceral pain that the woman can't explain due to involvement of the autonomic nerves in the pelvis. Apart from the pain, infertility, of course,
Correct.
due to many factors. Sometimes we can't explain it. But it's not only the anatomical disruption of the fallopian tubes, affects the egg quality, the number of eggs. It does affect the implantation of the embryo inside the uterus. And most women don't know that endometriosis causes recurrent miscarriage, which we consider it a fertility problem as well. Even during pregnancy, it has an impact. The dysfunction, we're talking about bladder and bowel dysfunction. Many women go to urologists with the bladder problems, and they don't know it's due to endometriosis. It does cause that. So they go to urologists, and if they don't have the experience about endometriosis, they just don't reach the right diagnosis. The same for bowel. It comes with constipation, bloating, we call it endobelly, difficulty emptying the bowel, bowel pain. All these women go to gastroenterologists. They don't go to endometriosis specialists. And this is why there is significant delay in the diagnosis of endometriosis, because patients present with different symptoms that are not gynecological and go to different doctors, not an endometriosis specialist.
This is, I would like to emphasize that it's really important to go to specialists, to go to experts, to go to professional with the experience and advices that you can somehow diagnose this kind of health issue earlier.
Correct.
And Dr. Luciano, for in your perspective, for the infertility, the endometriosis, of course, it's making a big problem. How big problem it's for the infertility itself, the IVF process, and
I think when patients come to clinic, we need to make very clear if the problem is mainly pelvic pain or is fertility related. Because if it's a pelvic pain, the pelvic pain has to be treated first within a pelvic pain setting. If it's a fertility, obviously we need to investigate the fertility potential. But in some patients, of course, the two problems are equally important. They want to have a better quality of life and they want to have a family. In this case, there are some established and published guidelines for the management of patients with endometriosis-associated infertility. And depends on where is the endometriosis. If the endometriosis is just in the pelvis, so as a superficial peritoneal endometriosis causing perhaps painful intercourse or some scar tissue that could impact on the normal anatomy of the tubes and the ovaries, or for instance, if the endometriosis presents as a cyst in the ovaries. And depending on the size of the cyst, then we may need to decide whether the patient will benefit from surgical intervention or from conservative management. But of course, when there is a potential risk or there is a place for surgery, we need to warn the patient about the complications. because the surgery can come with complications, especially if patients have cysts in the ovaries. When we remove the cyst, there is a risk that their ovarian function will be diminished. And diminishing ovarian function means actually we end up collecting less eggs. So there is always a fine balance between offering patients management for pelvic pain or prioritizing their fertility wish. But in most cases, we need to rely on appropriate evidence and the latest guidance and evidence-based practice.
Thank you so much, Doctor. Would like to also ask the important question: what are some of the modern approach nowadays available for managing this pelvic pain or fertility-related concern, and as well as endometriosis?
Well, as Professor Luciano said, we need an individualized assessment first to understand the type of endometriosis and its impact on fertility. Before we plan any management, we have also to discuss with the patient. Some of my patients, we refer them for egg freezing first, and this is recently having significant attention of many patients before we consider surgery. Medical management is generally considered against fertility, and it's aimed at controlling pain because it's a long term, whether it is before surgery or after surgery, to reduce recurrence. In the surgical field, we use the latest technology from laser to harmonic energy in order to reduce the damage to the tissues. And we have modern techniques of trying as much as possible to preserve the ovarian reserve if we are doing surgery to remove cysts, like ablation of the cyst only, allowing the IVF specialist to do the egg collection, and then if in the future it recurs, then we do proper surgery. Some patients, we do a stage approach. So we send them for egg collection first, then we do the surgery before the embryo transfer. And this is in liaison with the IVF specialist. Of course, we get the best results. So I always say it's a teamwork between us as a surgeons and the IVF specialists.
I see. And Dr. Luciano, in your practice, is there any case that you would like to share with us when you use this kind of modern technology or the new approach for the patients with the pelvic pain or endometriosis to help to achieve their dream?
I think it's very common practice, and I have patients that have pelvic pain, but they are concerned about their fertility because of perhaps chronological age. And in these cases, they will prioritize fertility because time is of the essence. So if they keep waiting and they get the pelvic pain solved first, maybe that in time the ovarian function will decline and the potential to achieve a successful pregnancy will be lower. So this is an instance of a multi-steps approach where patients can perhaps embark on fertility treatment, create embryos. In the fertility clinic, we cryopreserve safely the embryos with a very good success rate in terms of thawing of the embryos. Survival rate of cryopreserved embryos is higher than 98%. So we can cryopreserve these embryos, and the patient goes back to the endometriosis specialist with a view to dealing with the endometriosis, maybe a combination of surgery and medical management. And once she has completed that process, once she has restored a normal, good quality of life, then we'll come back to the fertility clinic with a view to having an embryo transfer and embarking on a pregnancy. This is common, where patients will choose first to cryopreserve other eggs or embryos, depending if they are in a relationship or not, then deal with the underlying gynecological problems, and then come back at a later date for fertility treatment.
Great. So, Dr. Charles, if there is one message you could give a woman who might be silently experience the symptoms that we just discussed, what it would be?
Stick to your gut instinct. If you have pain, that means you have pain. So keep searching for endometriosis specialist or pelvic pain specialist to investigate further, and don't accept negative finding of investigations as an answer, whether it is ultrasound scan negative or MRI negative even. And always stick to regular checkup. I would advise even every 6 months. If you don't have symptoms now, you may have symptoms later, so you need to get checked regularly. Maintain a healthy lifestyle. Keep your weight within healthy level. Exercise regularly, and speak about it. Don't feel shy that you're in pain, any type of pain.
Great. And what about you, Dr. Luciano?
I think my constant message to patients is to make sure that they are aware of the possible causes of their symptoms, and not to be afraid to speak up, not to be afraid to visit a specialist, and in some cases actually not to be afraid to talk to family members or friends, because in their community or communities there may be many other people that have the same symptoms, who have experienced the same symptoms and have found a solution. So speaking to others, being open about the symptoms, being open about what the personal experiences, in some cases actually helps women to come to terms with the underlying problem and to find the right solution, rather than delaying the time to reaching a diagnosis, and certainly to improve the overall quality of life.
Great. So thank you so much for today, Dr. Charles and Dr. Nardo. It was very nice for sharing their valuable insight. And today's conversation is the powerful reminder that women health is important. Awareness is important. By understanding our bodies, listening the signals, and seeking for the right support with the right expert and specialist, it's the important. So thank you so much for today, and I hope that all women will benefit from this conversation and get the right results that they needed.
Thank you.
Thank you.
Thank you.
Thank you.
So the question what I want to ask is about the perimenopausal stage. So how the stage of the perimenopausal can affect this pelvic pain or endometriosis. Is there any link between that woman is close to perimenopause, that she might have this endometriosis, or it's not?
Endometriosis presents anywhere between the age of 15 to 50 even. And the significance increases and the symptoms are more with the younger age. But reaching the perimenopause state, I have seen women reaching that stage without a diagnosis for nearly 25 years.
Mm-hmm.
So women assume that with the perimenopause and reduced ovarian reserve, that the pelvic pain will get less. But it is not. The pathology is there. And as long as we don't know the cause for the pelvic pain, we need to investigate it. So don't assume not only the perimenopause, reaching the menopausal state, that it will be the sort out for the problem. It is not. We have operated on women 60 with endometriosis that was not treated. Of course, sometimes the symptoms calm down a little bit, but it will not disappear. So at any age, even if you're approaching menopause, you need to seek advice for the pelvic pain.
Great. And I want to ask Dr. Luciano one more question. What is the right age, or not right age, the youngest age that you can start to think about to freeze your eggs?
In theory, you can start planning the freezing of eggs at at any age. There are reports in the literature of very young teenagers freezing eggs. But of course, depends on the infrastructure within the fertility clinics, depends on the country, because different countries have different licenses when it comes to allowing the freezing of eggs in underage girls. And of course, also depends why we are intending to freeze eggs, and in some cases having the consent of the parents to freeze eggs. But of course, we cannot ignore that in this day and age there is ongoing research about freezing ovarian tissue, which seems to be a better option in younger women. Freezing ovarian tissue enables the transplant of this tissue inside the pelvis at later date. So the egg freezing is available to any woman as long as there are follicles to be developed and is possible to retrieve eggs. But whether it can be accomplished, it is not just depending on the clinical decision or clinical choice. There are multiple factors that take into that help to make that final decision.
Yeah, I think there is the many women who is maybe first or going to this journey for IVF. They might ask themselves or even the doctor, if I will start, like maybe I previously have the issue of the endometriosis and then I kind of heal it or cure it with some medicine or anything. And if I will start IVF, would it be comeback or would it be cause more difficult issue on the health?
Yeah, I think the generally speaking, there is no evidence to support the fact that fertility treatment involving ovarian stimulation of the ovaries will lead to worsening pelvic pain symptoms or worsening the stage of endometriosis. Any ovarian stimulation will be limited to a short period of time. And generally, in women with endometriosis, we will opt for certain protocols that will limit the increasing of the estrogen levels. So the stimulation protocol used for a patient with endometriosis is generally different than the stimulation protocol used for a patient without endometriosis. And this is where individualization of treatment and personalization of treatment protocol is very important. So the misconception that women having fertility treatment will see a worsening of the pelvic pain symptoms or of the stage of endometriosis, I think doesn't stand. And women should seek adequate expert advice from fertility clinics as well as from endometriosis multidisciplinary centers in order to be reassured by the fact that fertility treatment doesn't worsen the endometriosis.
I see. And
we also need to remember that endometriosis is a very slowly progressing disease over many years. And the ovarian stimulation, whether it is in IVF or even in clinic, it's a short period of time. So the spike in estrogen is extremely unlikely, and it doesn't in real life make the endometriosis worse. And we don't stage endometriosis. So patients will not move from stage 1 to 2 to 3.
Okay.
No, it's types. And it stays as types. It can progress, like the superficial one or the ovarian blood collection or the deep one. It stays like that. It progresses.
Mm-hmm.
So definitely the IVF treatment or the ovarian stimulation does not make things worse, does not have any impact on the patient's symptoms. And it is definitely advisable to, if the patient doesn't have many symptoms, to seek the fertility preservation first before dealing with the endometriosis
Itself.
Of course, it's individualized. Some cases we have to do the surgery first to make the job easier for the IVF specialist to be able to reach the ovaries and do the egg collection. So each case by case, we discuss it together to reach the best management for this patient.
Exactly. And what about pregnancy? So when the woman, for example, pregnant, on the different trimester, I would say, and suddenly she's having some pelvic pain and then maybe diagnosis with the endometriosis. How you look at that patient who is in this situation?
This is very important and very common question and perception that pregnancy is a treatment for endometriosis. Most patients will have less symptoms during pregnancy because naturally the hormone progesterone equalize the effect of estrogen, and the symptoms and the inflammation will calm down. But the disease doesn't disappear. It will continue after pregnancy. But during pregnancy, it's unlikely the patient will have symptoms of pain, except if there is any significant adhesions and the stretch of the uterus in the pelvis, it can cause. But in most patients, this is very mild and can be managed with simple analgesia. Of course, if the patient had a big cyst and it suddenly ruptured or so, this is a different and extremely rare complication of ovarian endometriosis. But most women will have no significant pain in pregnancy.
Great. Thank you so much for your time. I
Thank
think
you,
we're over for the time. It was
it.
great conversation.
It's a pleasure.